Because it's a question that we get all the time, and it's confusing to people. What is the difference? Everybody kind of lumps it together with hospice, and then they're like, no, no, we don't need that, you know. So I think we're going to go ahead and get started because I know that you guys have busy days. So I want to honor your time. And the reason that I was really compelled to do this is because, I do work with Compasses Hospice. And what really brought me to hospice was last year when my father passed. And, he was in Florida. It was during the pandemic. And we couldn't get to him. We were driving because we couldn't get a flight. And he ended up passing before we got to him. We were fortunate enough to have an amazing hospice that was there to support us and help us along the way. And I know for a fact that each one of you know the value of hospice, and there's so many to choose from in the Valley. And I am the first person to say that I don't think I've ever come across a bad hospice. I mean, the work is generally, from people who have been touched by hospice are generally the ones who work in hospice. So I always like to give great praise to my colleagues out there that are doing the same thing. One of the things that I wanted to really bring focus to, though, is the palliative care. And I really want to see more and more of this. And the reason that I'm so passionate about it is because I'm actually on palliative care. So I don't know if many of you know, but I do have pericarditis. And so what that is your heart has a sac that holds it. And there's a small amount of fluid in that sac that helps the heart to be able to beat and not cause you discomfort, right? So it helps it to easily move within your chest wall. Well, with me, I ended up getting MRSA, which affected my heart. And I ended up getting the pericarditis, which inflamed that sac. And then I ended up getting fluid buildup. So it caused me to have shortness of breath, chest pain, just extreme fatigue. It felt like I was having a heart attack. But this is back in 2013. Well, I just turned 50, so I'm young, right? So I'm like, no way I'm having a heart attack. I thought, well, maybe it's reflux or something, and ended up being that it was pericarditis. And so I started being followed by a cardiologist. Nobody ever mentioned palliative care to me. It was just going to the cardiologist, let's treat the symptoms, let's get the fluid down, and keep going on with your life. Well, for me, it became a chronic illness because I continue to have bouts of the pericarditis. Again, nobody has mentioned to me anything about palliative care. The frustrating part for me is at the time I was the director of patient services at Valley Sleep Center, and I held a very stressful, very demanding role. And so it was really hard for me to stay in that role when you get pericarditis, it knocks you out. I'm not supposed to have my heart rate over 100. Well, walking across the room, my heart rate would escalate up to 170. It was crazy. So I was like, oh my gosh, I don't know what I'm going to do. I ended up going and taking another role after I took time away just to get healed. I stepped away from my role at Valley Sleep Center. I took another director position and I created a marketing department for BackFit Health and Spine. But again, I ran into the same problems where after 3 years, it was such a struggle with my pericarditis, the level of stress, and trying to manage my life. So I did independent consulting for a while so I could manage my own schedule. And then when I got involved with Compasses, that's when I learned about palliative care. So this is just last September, I learned about it. And I said, I have to know more about this. So I did a consultation with our palliative care nurse, and she has been a life changer for me. Now, is my pericarditis gone? No, it's not going to go away. But when I sat with her, I said, look, Christy, I want to be able to function during my flare-ups. I want to be able to still work, but the medications that I'm given, they make me so tired. I can't even function. And she's like, we can work around that. So she was able, working with me and listening to me one-on-one, to get me on a regimen of medications similar to the medications that my cardiologist was giving. But my cardiologist's main concern was just get it resolved, right? Let's get it resolved. But Christy took that extra layer of support and really listened to what my main concern was, which my main concern is I love to work. That is what drives me. And so for me, it was important to have a a regimen of medications that allowed me to continue doing what I love to do. So she's been able to do that. And I can't thank her enough. So being part of a support group for pericarditis, I started reaching out to them saying, hey, are you guys familiar with palliative care? They're like, no, we don't know anything about it. I said, okay, I need to start stepping out of my comfort zone, and I need to start educating and sharing my experiences with people and how it can benefit you. I've been reading, dementia is a diagnosis that we see a lot in the residential assisted living homes. Well, I don't know if you know this, but with dementia, the earlier you start with palliative care, the better the outcome for the resident and the family. And a lot of that is just having that person who's specifically looking just for that disease process, right? Just following that process and really communicating with your other providers and communicating with specialists and communicating with the family and seeing those small little things. And then they become a resource for you as the residential assisted living homeowner, because they can say, hey, you know what, Barbara, I'm starting to see this type of a decline. I think if we do this, we can help guide this a little bit better for her and help prolong, this from happening. So there's a lot of value there. So the greatest myth that families feel is that my family member, my loved one, must be dying if they're going on palliative care. Well, I'm here to tell you, as a testimony to palliative care, I'm not dying, but I love my palliative care. And it has not only helped me, but it's helped my family during the pandemic, right? When nobody could go to the hospital with you. My family was so nervous because I have had to go to the hospital for my pericarditis before. And so my nurse practitioner came to the home, met my family. They all know her. And that she's like, you guys, if Patty's admitted, I'm allowed in the hospital. I can treat Patty in the hospital, which is different than hospice, right? So in the hospital setting, if I needed to go, my family had the comfort of knowing that Christy would be able to get in to see me and give them a real account of what's going on, because it's really hard to get that information when my family's not clinical. They don't know what to ask. And if I'm undisposed and I'm not able to communicate with them, they have that comfort of knowing that Christy can do that for them. And that's regardless of the pandemic. So let's say that we are, we're starting to see things return to normalcy, but still my family doesn't know what to ask if I get admitted. Christy knows what to ask. Christy knows what to see that I'm being guided correctly. And then you can take that one step further. As a homeowner, when your their loved one is admitted, you can still follow very closely, because you can say, hey, Christy, as the nurse practitioner, can you go and visit John Doe and just see how he's doing and check on him? And that's a peace of mind for families, especially when they're out of state. But not only the families, but for you as well, because how many times have you had a resident be admitted that you don't know what's going on? And that's really frustrating. So that's a really nice benefit as well. Another thing about palliative care is the challenging family dynamics. It is really hard sometimes to help families understand the progression of the illness, or to help them with education pieces along the way. You guys are in there, you guys are delivering the care, but sometimes it's hard to have those conversations. And sometimes the family dynamics are challenging. Well, our nurse practitioner is really good at being able to communicate to families and really with empathy, share real time what's happening and what they can expect. So it kind of takes some of that stress and pressure off of you as a homeowner, because she's having those conversations with them for you or with you, however it works best in your home. Another thing that's really nice is that, she can help guide those goals of care. So when we are seeing that things are needed, let's say that you have a resident, they're in need now, they're starting to decline to where maybe they do need additional, like a wheelchair now, and they didn't have one, or they need whatever it is with medical equipment. Our nurse practitioner can help coordinate all that. And mind you, while she's doing all this, she's communicating with any providers that are on site. She's communicating with any specialist, as well as you and the family and the loved one. So everybody knows what's happening. We can provide social services resources to them, much like hospice. What we don't do in palliative care is you don't have that nurse support that is, twice a week, 3 times a week. And that's simply because at the point of palliative care, that's not necessarily needed. If and when it gets to my point where I start to progress in my illness, and my hospice nurse or my palliative nurse has had this conversation with me and my family already, that we know that it's only going to get worse. We've already seen it, me declining with age. I'm getting ready to get a pacemaker, and I'm only 50. So my SA node has been impacted by the pericarditis. So as I'm going through these steps in mind, Christy has been able to be there to help educate. So my family knows that when the time comes where I am going to need hospice, they feel very comfortable with Christy having that conversation with them because they know her and she knows me. So when that difficult conversation, and that's not an easy conversation to have with your families, she's there to let my family know and to be a comfort to my family and support them when that's time for that difficult decision. So that's another nice added support that you can have for your residents, which, let's face it, they do become like family as well, and for their families too. Another thing about palliative care is people are like, well, do they have to be homebound? No. Your patient does not have to be determined homebound. So I know sometimes a mobile doctor may have very strict criteria for your patient to be able to have mobile visits. Well, with palliative care, there is no criteria for homebound. Anybody can meet criteria for palliative care. So when you've got that resident in the home that really needs that extra attention, our nurse can come out and do face-to-face visits with them, and they don't have to meet that homebound criteria. So that's a really nice added benefit that a lot of people are not familiar with. Commercial insurance. Yes, most commercial insurances have coverage for palliative care. So not all, but we do our best to work with our families to make it affordable for them. So I would say that of the families that have been referred, I honestly think maybe only 1 or 2 have not come onto service because of insurance. And a lot of them, it was more like they were waiting for an insurance change and then they wanted to reassess. But we work really closely with them on that because, finances, that can impact our health, right? Because that's stressful. So we really try to take that stress from them. And currently right now, because of the pandemic, we're still able to do a virtual visit at no charge to your resident, which is really nice, especially if they're just interested in palliative care. They just kind of want to, would this work for me? Would I like the nurse practitioner? They can kind of do a test drive at no cost to them under the virtual visit. Now, there are certain diagnoses where we do need to do in-person visits. So, but that initial visit to find out how we can help, you can get that virtually at no cost to your resident, which is really nice. Medicare does cover palliative care. Medicaid, that's one where we have not seen coverage for the palliative care. But again, we've worked with families at very low co-pays because we see the value in our palliative program. So we work with them really closely on that. Your team with your palliative care is going to consist of your nurse practitioner, your social services, and your chaplain. Now, it's not like with hospice. Again, hospice has a much bigger scope, right? So you've got the physician, the nurses, the nurse practitioner, the social services, trained volunteers, hospice aides. So you have a larger group of support for hospice, but that's because as my disease progresses, I'm going to need that extra layer of support. Right now, I don't need that extra layer of support for my diagnosis. Another common question is, what type of diagnosis qualify? You would be amazed at what diagnosis qualify. Pretty much any chronic diagnosis. So if your resident has diabetes, they qualify. Why is that a benefit? Because we're going to help you guys keep your patients' sugars where they need to be. And we're going to be that extra layer of support. Dementia, the sooner you get them started before they start showing signs. They have done studies that palliative care should be initiated at the onset diagnosis of dementia. It could be heart disease, it could be COPD, it could be fibromyalgia, believe it or not. It could be pericarditis, it could be lupus, it could be any autoimmune disease will fall under that diagnosis. So truly there's not anybody, it's very rare unless they're healthy. We can help and we can offer you guys that extra support and with your residents. So I'm going to open it up because I know you guys' time is valuable. Let me know what questions you have, or maybe that I haven't covered or explained well. Anybody?
This is Hal. I got a question.
Yeah.
So I know hospice is like a service that you can't really do a lot to try to fix or cure people of their problems. Obviously, a lot of these problems are incurable, but is palliative care give you more wiggle room in terms of treatments to help the individual improve, or is it more like comfort care like hospice?
That's a great question, Hal. I'm so glad that you asked that. So think about me as an example. I always like to use myself as an example because it helps to put things in lifetime, or real life. So for me, with my diagnosis of pericarditis, I am under palliative care. I am not doing just comfort care, right? Because I'm actually meeting with my electrophysiologist on the 20th to get a pacemaker. And I can do that under my palliative care. I can seek any curative treatments. I can do physical therapy. I can do occupation.
Download the DraftKings app right now. Use the promo code, get a free shot.
Radu, I think you're breaking up a little bit. Can you?
It didn't work out. They got their guy. Guys just won a Super Bowl. Listen, AT, using Pepto Bismol. All right, fair. You got.
Radu, did you have a question?
No, you pretty much. I got in the middle of it. You pretty much explained what palliative care is. So that was more of my question as far as how often the nurse visits, and because we have one resident, that we have that's on palliative care.
It's generally once a month, unless it's needed more.
Okay.
So, but generally you're going to, cause I see my nurse once a month and even I see her even if I'm feeling okay, just because I like to have that touch point with her.
Oh, okay.
Mm-hmm. Yeah. I don't have to be like declining to see her, or I can, if I don't want to see her that month, I can say, yeah, you know what? No, I'm good this month, but I like to see her every month just because I like to have her.
How do you see her more than one time a month?
When I have a flare up, yes. When I have a flare up, I mean, I've seen her twice a week.
Okay.
Yeah. So, and she's come out to the home. So she's done virtual and home visits with me, which is really nice. Yeah. And for me, it helps keep me out of the hospital, which I think a lot of families can appreciate right now. We don't want our loved ones to have to go to the hospital. I know that we're coming on the cusp of seeing things get back to normal, but still, I don't want to go to the hospital. So generally my cardiologist, if I call them and I say, I'm having a flare, they're like, go to the ER and we'll see you after. And I'm like, oh my gosh. And so I will call Christy and say, Christy, can you come out? Yes. Christy will come right out to my house. Tavi, I noticed that you joined us. Welcome. And Tavi, we are recording this, so I'm going to go ahead and I will give you a recording. I'm also going to be putting together a little handout that you can also use as reference from the points that we talked about today. Are there any other questions?
Yeah, I've got another one.
Yeah.
Maybe it's covered in the handout, but if I talk to my managers or caregivers, what would they look for in someone that might be a good candidate for palliative care, that we bring it up to their family? Just any kind of chronic disease or?
Yeah,
anything?
anybody who has a diagnosis that could benefit from additional support. And by that, I mean, and I think what I'll do in the handout, I think what I'll do is I'll break it down a little bit by some of the common diagnoses that you see. But like with dementia, again, like I said, They suggest that as early as onset to get palliative involved. Diabetes, high blood pressure, heart disease, congestive heart failure, COPD, asthma, autoimmune diseases, lupus, ALS.
So if they have any of those, we should at least offer it up and tell them,
Yes.
there's this extra service here you might want to check into.
Yeah. Yeah, absolutely. And what's nice about it is at that point, they're still under private insurance, right? So at that time, or even if they have Medicare, but they're still Medicare, the palliative is covered, by the way, 100%. So that's really nice. But having to navigate sometimes when hospice comes in, we will automatically, we provide beds, we provide the, all the equipment and but you don't always get that if you're not on hospice. So families might be like, wow, it would be really nice to have somebody help me navigate my insurance to get dad a wheelchair. It'd be really nice to have somebody help me navigate to get these supplies that we need. And that is something that your palliative nurse is there to lean on for the family to go, hey, can you help guide us in this? And that's what she does.
Great, thanks.
Nice. Yeah.
Mm-hmm.
And I want to make sure that everybody gets credit for being here today, because I am going to be giving away it's a fidget widget twister. It's a cool toy for anybody that has dementia. And so I shouldn't say toy, it's a tool. But I'm going to be giving one of those away. So I have down that we have Tavi and Barbara. Could you guys do me a favor? Can you just whatever I do, can you put your name in the chat with the name of your home? And then I will make sure that I put you in my raffle to win. Does anybody else have any questions about palliative care? These were all really great questions, by the way. Hello. Wonderful. And I did mention a little earlier that we are recording this, so I will be getting you guys all a recording. If there's a particular email that you would like that to go to, if you could include that as well. If not, I'll text you if I don't have one. Because I love to text. So I think what I'll do is I'll do a little quick recap, because we've had some late joinees, and anybody who needs to jump off, I completely understand. But basically, we were just talking about the differences between palliative and hospice care. And some of the main differences are with palliative care is not end of life. At palliative care, it is on the onset of diagnosis. As early as the onset of diagnosis, you can receive palliative care. And palliative care is covered by most commercial insurances, and similar to hospice. And what else did we talk about? We talked about the team that would support the resident, which would be your nurse practitioner, chaplain services, and social services. The nurse practitioner could come directly to the home to see the resident, treat the resident. She can follow them to the hospital. So if your resident is admitted to the hospital, or a family's loved one is admitted to the hospital, we can go there and be that communication and to let them know what's going on. And when you read it, when you watch it back, I kind of go into more detail on that one as well. We can also help with challenging family dynamics. We can help speak to multiple family members. We can help them to understand kind of the progression of the illness. We can have that conversation with them, the hospice conversation, which can be a very difficult conversation. I find it to be an easier conversation, having pericarditis, being on palliative care. I'm not dying, but when that time comes for me to go on hospice, my family has already met my nurse practitioner from palliative care. They're already comfortable when she starts saying, you guys, this is what we're looking at. They're already more comfortable. It's never going to be easy for them, but they're more comfortable with that conversation now, which I feel like oftentimes hospice is entered into too late. And so palliative care actually is a way to make sure that your loved one is getting the benefit of hospice services and that comfort longer than just 24 hours, which it's sad to say, but sometimes we see that quite often, and that's heart-wrenching. So, and then also, what did we talk about? Right, I'm trying to hospice. Oh, and then curative treatments. You can still have curative treatments throughout palliative care. I myself, I'm getting a pacemaker in April. So yeah, and I'm on palliative care. So you can continue to get your curative treatments. That's not a problem with palliative care. It follows you right along the way. So that's a major difference between hospice and palliative care. And then, you know, I do not have to have a life-limiting illness. I just have to have a chronic illness. And trying to think if there was anything else that I could recap in our conversation. If I'm missing anything, you guys let me know. If you have any questions, anyone that just joined, I'm happy to answer them.
Patricia, this is Barbara with Harmony.
Hi,
I
Barbara.
really appreciate your information. I've been in the group home setting for a few years. I've been a nurse for many, many years. And I really worked a lot with hospice, but not so much with palliative care. And I'm finding that you are correct that I think in hindsight, in looking at some of my patients, residents, that they would have benefited from hospice or even earlier on with palliative care. So you transition from one to the other, correct?
Correct. Correct.
Okay, and you have all those services, correct?
Correct. We have all those services, which is, it's nice because I think of my family and I think of with my dad, it was really hard to hear he needs to be on hospice and we couldn't even be there. Had I known about palliative care earlier, he would have fit the bill. He had high blood pressure, AFib, he had stroke, he had diabetes, dementia, he had it all, the full gamut. Had I known about palliative care, he would have been followed by a nurse so that it wouldn't have taken a hospital visit for him to, you know, decline to the point of, I mean, he passed within 8 hours of being on hospice. It was so
Oh
sad.
my, I'm so sorry.
Yeah, it was horrible. And so if I can prevent one family from having to go through that, then I've done
Yeah,
my
I've had situations where they're barely here and they're already needing to talk hospice, and the next thing they're already gone. And hospice maybe just barely got their foot in the door, maybe had that one visit or two visits even in that 1 week. And it's a lot to take in for a family. And it would be wonderful if there was a step before that.
Exactly.
And insurance does cover that, correct?
And most insurance, I'm going to say, I'm not going to say all, there's so many of them, but Alicia, she works in our office and she's amazing. And like I said, Barbara too, we work with our patients because we do see the value in our palliative care program. And I'm really passionate about it. So I'm always like, okay, so what's their coverage? How can we work with them financially if finances are a burden? So that's something that we definitely look at individually for every patient that comes onto our palliative care.
I see. You know, this is a really enlightening information that you have given today for myself, and I'm sure for others. I was asking to know if maybe you would consider maybe even doing education units on different things and having us meet those needs for like managers and staff that need education units.
Absolutely. Absolutely. I'll get with my director on that. And then I'll get back with you guys on that. But absolutely. Okay. All right, you guys, thank you so much. Everybody who joined me today, you are entered in the raffle. And what I'm going to do is, are you guys all following on Facebook? Following me on my personal?
Yes. Yeah, I am.
Okay, perfect. If not, this is the name that I'm under. And I'm going to be announcing so everybody can see who won on my page. But I'll also, I will also be texting the winner as well. I won't give you all a text, but I'll text the winner and then I'll put it on my page. So.
Okay, sounds good. Thank you for that.
Thank you guys so much for joining me, and I look forward to having another talk again soon.
Thank you. Bye-bye.
Bye-bye.
Bye. Thank you.
Bye.
Leave room. Leave.
Ako turuan mo kung ganyan.
Leave.